I'd like to welcome everyone to our webinar, sponsored by the Global Tracheostomy Collaborative. I'm Linda Morris, and I'm your host for this webinar. And our topic today is going to be creating a tracheostomy safety program across the continuum, in the hospital, in the office, and in the home. We have a great lineup of speakers today, and I'm sure you'll get a lot out of it. It's very exciting, and we're all happy to be here. I'm going to be talking about tracheostomy safety in the hospital. Dr. Lisa Wolf is a board-certified pulmonologist and sleep medicine physician who's going to be talking about tracheostomy safety in the office. And we have Christine Nee Chong, Jenny Messer, and Tanis Cameron from Melbourne, Australia at Austin Health, and they're going to be talking to us about tracheostomy safety in the home. First of all, this webinar is offered by the Global Tracheostomy Collaborative, and we thank our generous sponsors of Medtronic and Smiths Medical for their generous contribution to help make this webinar possible. The GTC does not endorse the content offered by any of its presenters today. And so I'm going to start my presentation of tracheostomy safety in the hospital. My name is Linda Morris. I'm a tracheostomy specialist, and my current job is in nursing research, but I also still keep busy seeing tracheostomy patients. Before I worked here in a rehab environment, I worked for 12 years as the respiratory APN and trach specialist at Northwestern. I also want to disclose that we have a book out, Tracheostomy is the Complete Guide. It is currently out of print, but a new edition is coming soon, we hope in early 2019. And I also do some legal consulting, some of which involves trachs. For this hour, at the end of this hour, you'll be able to develop strategies to implement a tracheostomy safety and quality improvement program in the hospital, in the office, and in the home. You'll be able to describe components of a comprehensive teaching program for staff, patients, and caregivers. And you'll be able to review strategies to handle tracheostomy planning and emergencies. So let's first talk about tracheostomy care practices. I currently work at, as I said, in an inpatient rehabilitation unit, or inpatient rehabilitation hospital, I should say. And we created a tracheostomy bundle. And this wasn't our idea, this came from St. Mary's Hospital in London, and some of the people who are in the GTC helped to work on this paper were we organized a tracheostomy bundle, and our tracheostomy bundle consists of supplies as well as care practices. And in the original bundle developed by St. Mary's is for an acute care hospital, but since we work in an inpatient rehab hospital, our needs are a little bit different, so our bundle is just a little bit different. We do the same in rehab. Most of it is the same in rehab. They have bedside supplies, but since many of our patients spend up to 3 hours in therapy, our patients also need traveling supplies So they have one set of supplies at the bedside and another set for traveling attached to their wheelchairs. We've been in this brand new hospital for about a year and a half, and part of the planning for the hospital was determining specific locations for our tracheostomy supplies. So we have specific cabinets where our trach supplies are kept, and the nurses check those supplies, nurses and therapists actually check those supplies every shift to make sure that they are always available. Our tracheostomy care practices are also important as well. We also want to ensure that humidification, that we check humidity and make sure that our patients are in adequate humidity. We also check the inner cannula frequently and clean the stoma every shift. We also want to make sure that the dressings are changed, the supplies are checked, the cuff status is documented, whether the cuff is inflated or deflated, and we want to make sure that the trach ties are secure. That's especially important in our patients in rehab because they're going to therapy, they're going back and forth, and so the decannulation is always a risk, and we need to be aware of that. We also want to make sure that we check patency of the trach every shift by one of several methods. We also want to check the functionality of the suction system, change the suction canister and tubing, and oral care is very important for our patients as well. We put all these together in a one-page tracheostomy checklist that we ask the nurses to complete. It's kept at the bedside, and we put it in laminated paper so that they can hang it on the back of the cabinet and then check off the supplies as they go, and then so that they know which ones to replenish. And it's also the basis for our documentation system as well, which is important from a legal perspective to make sure that we have all of the tracheostomy supplies at the bedside as well as our care practices are documented. One thing, to summarize our trach bundle, I like to use the acronym SHIPS, an ounce of prevention, by just simply doing some simple measures like checking the stoma and keeping it clean, keeping the trach humidified, checking the inner cannula frequently, checking patency of the trach, and making sure that we always have supplies present. We can ensure optimal tracheostomy safety in the hospital. Another part of this comprehensive program is an education program for staff as well as for patients, families, and caregivers. And so our training groups, we have trained a large number of disciplines and people. Nursing is primary, as well as our physical therapists, our speech therapists, occupational therapists, of course, respiratory, and our physicians and residents, but also, we also want to make sure that we include our techs and our aides, our PCTs, we call them, patient care techs. Excuse me. Our nurse curriculum, we have 3 modules. These are online learning modules. The nurse curriculum is most comprehensive. It includes module 1, focuses on the daily care of patients, stomach care, suctioning, dressing changes, etc., inner cannula and showering, keeping the trach ties clean. Module 2 is all about emergency management. What happens, what can we do to prevent emergencies, as well as how can we manage them if they occur. And module 3 talks about types of trachs and precautions for each type of trach, downsizing, the downsizing process and why that's important and how that happens. Also, it's important for nurses to understand the difference between capping versus a speaking valve versus using an HME. And then also trachs versus laryngectomies. And one other thing too that's not on here is T-tubes. We've been having a lot more T-tubes lately. So we want to make sure that nurses understand what those are as well. Our patient care tech curriculum includes how to use the ambu bag, how to shower patients safely, and that's mainly preventing water from entering the trach. And red flags, what are red flags? What are the warning signs? When do they need to call the nurse to come and look at the patient? And how can we get the patient to therapy safely? So the PCTs are the ones who gets the patients to and from therapy, so they need to be the ones to make sure that the patient has all the equipment that they need. And they are also the ones who provide most of the oral care as well. Respiratory therapist curriculum includes all about the downsizing process, how to change the trach competently, how to manage emergencies, patient and family education, also about trachs versus laryngectomies, and also red flags too. Everybody needs to know about red flags. Allied Health has basically one module, but we have some additions for speech and OT. All of the Allied Health need to know about emergency management, suctioning, using the ambu bag, and the red flags. Speech needs additional information about downsizing and phonation with a tracheostomy tube. And the OTs need additional precautions about showering. The residents and attendings, rather than doing the online learning modules, they prefer to get their education in person. So I've provided lectures for the residents and the attendings, talking about the trach checklist or trach bundle, how to manage emergencies, what are red flags, a little bit about the downsizing and decannulation process, and also about types of tubes and when to use different types of tubes for different conditions. Patient education is an important thing, and currently this is primarily done by the respiratory therapist, although the nurses also help to participate in patient education as well. We give education to the patient and family on suctioning, stoma care, intercannula dressings, when to call the physician, and also how to manage an emergency before the ambulance arrives. We've put together a skills checklist for patients, families, and caregivers. This is just the first page of the checklist, and it has space for when the staff did a demonstration, when the patient did a correct return demonstration. Any clinician comments can be indicated here, and when the clinician signs off on that particular skill. We also have a tracheostomy care at home manual, if you will, talking about those same things, so patients get written information when they go home. And I'm not going to spend really any time on that because Christine is going to be talking about trach care in the home. So our tracheostomy safety program is patient safety in the center, but it consists of patient assessment, education of staff, patients, caregivers, a multidisciplinary approach, and creating a safe environment. A big part of our success has been our tracheostomy champions, who are unit representatives from a multitude of disciplines: nursing, allied health, patient care techs, respiratory, as well as medical. And the trach champions meet monthly. I do trach rounds weekly, and as part of the trach rounds, I create a report that I send to the managers, and so that they have the opportunity to follow up on any deficiencies that I have noted. And part of that is the trach checklist too, and I will let them know if there's supplies missing or things like that. So during trach rounds, we look at suctioning needs of the patient. We look at any concerns that the patient and family member may have. What are their goals for care? What are our goals for care? And what are the next steps in trach progression? And I put notes in the chart and send a report to the manager. This is an example of a trach report, that I've sent to managers. I've of course changed the names, but different kinds of issues, and the issues have improved as time has gone on, as people have paid more attention to tracheostomy safety. And this is the end of my talk. I'm going to turn over this computer to Dr. Lisa Wolf, who's going to talk about tracheostomy safety in the office.
Thank you, Linda. I am appreciating this opportunity to speak to the group and to work with the GTC. We're going to be talking today about safety issues for the office and clinical environment. In our summary today, we're going to be reviewing the goals that we have for our clinic. Let's start by looking at how the physical office should be equipped. The office should include equipment to provide safety to the patient with a tracheostomy and should be fitted with an in-wall suction as well as ceiling-mounted lights. Suction for safety, lights for assisting with trach changes. And although in many locations changing supplies may not be available in the office and patients may need to bring supplies from home, at a minimum, the clinic should have step-down tubes in case of emergencies. It's helpful to have silver nitrate sticks to help deal with granulations or bleeding around the stoma. And the environment itself should be disability friendly with a room size that's sufficient. Sorry. The room itself should be disability friendly with a size that's sufficient to have a patient with potentially a wheelchair and an attendant caregiver. The scales in the office should allow for measurement of weight for a patient even in a wheelchair. And if you can get electronic exam tables that can be raised and lowered, this will help with transfers in and out of a chair. You'll see in the picture we have here, we have a transfer board that's being used, and in some places, actual lifts are available. The next is to look at what your office staff needs to know. We recommend having a multidisciplinary environment. Just like the GTC and our group today, we have nurses, we have speech pathologists, we have physicians who are all working together to support the patient with a tracheostomy. Patients should be scheduled with extra time, as a standard return visit is not enough for a patient with a tracheostomy. And extra rooms should be assigned so that the clinic doesn't get backed up when you have this much extra time in a room. And if you can have extra supplies in clinic, it does help things go more efficiently. Work on plans for unplanned needs outside of clinic while the patient is in clinic. And if patients can meet support staff while they are there for a visit, things will go much better when they have emergencies out of the office. Families should be encouraged to come to the office so that they can also meet with the staff. When setting up your electronic medical record, there should be a trach plan involved. The flow sheets should include statistics about the tracheostomy, including the inner diameter, outer diameter and length, balloon type, shaft type, and any specifications or customizations that should be made. If you are going to have specific customizations, we recommend keeping a serial number so that if you ever need to go back and reorder the trach, the serial number can be given to the manufacturer so that you can recreate what's being used in the past. Also, document who the durable medical equipment providers are so that if the staff needs to order more equipment, they need to know who those orders should go to. Also, we would really encourage that as you design your electronic medical record for the office, that this data be kept in a flow sheet so that it could be exported for statistical and tracking purposes. When seeing a patient in the clinic, review with them what their airway clearance plan is. That could include things like a simple nebulizer or something as sophisticated as a mechanical cough assist device, a vibratory device like a Medaneb or an IPV, or a therapy vest. Regardless of these large mechanical devices, we recommend that all patients in the clinic be shown how to use an ambu bag, which is a resuscitation bag. It is light, it is portable, it is inexpensive, it can be helped to use to clear the tube, to augment cough, help a patient to even clear their nose, and should be available for all patients. Tracheobronchitis care is something that is usually dealt with by the office and the clinic, as it is an outpatient problem. The tracheostomy is, after all, a foreign body, and it is subject to the development of biofilms. Biofilms turn one-cell bacteria into sheets and layers of organized, functioning pseudotissue, which can promote infection down into the lung and cause pneumonia. To prevent this, we recommend oral care with antibacterial mouthwash and toothpaste, elevation of the head of bed at night, and reduction in inflammation due to gastroesophageal reflux. Frequent full changes of the tracheostomy tube with good cleaning of the tube before it's replaced is encouraged. Just changing an inner cannula will not help with this plan. And when evaluating patients that you think have tracheobronchitis, it's important to know that you need a tracheal aspirate. Full bronchoalveolar lavage should be reserved for those patients that have functional pneumonias. Occasionally, even doing suctioning above the balloon can help to find that bacteria which is being aspirated and causing pneumonia. You'll see on the slide in front of you what you would look for to define purulent sputum as the major reflection of the presence of tracheobronchitis. Greater than 25 neutrophils per high-powered or per low-powered field with a low number of epithelial cells is the sign that a patient should initiate therapy while awaiting for microbiology lab to give you specific sources and information about the sensitivity of the bacteria. We recommend considering the use of inhaled antibiotics when appropriate, as these can well treat and sterilize the large airways, which frequently are involved in tracheobronchitis. Those that have Pseudomonas, Klebsiella, or known multi-drug resistant bacteria are those that would benefit the most from treatment with inhaled antibiotics. And if we can treat those airways, we can reduce the chances that the bacteria will get to the alveolus, causing pneumonia. Next, we should talk about skin care. It's important to know that you can use things like zinc oxide to protect the skin. Most important, the skin needs to remain dry. Foam absorbent dressings can be very helpful for this. Avoid stretching the stoma. So for those that are using a ventilator in conjunction with their tracheostomy tube, make sure the ventilator tubing is placed in a neutral position because the skin will be much more irritated if it is stretched. Reduce irritation that can come from things like gastric acid, mucus, or even drooling saliva that can get on that skin and irritate it. The office should be a time to talk with the family and the patient about their communication plans. Does the patient use a communication device that either uses gaze, communicating with their eyes, or using their fingers to use communication electronic boards? Patients who can phonate well, do they have a phonation plan for their tracheostomy tube? In patients who can't phonate, if we can anticipate this ahead of time, we can use voice banking so that electronic communication can be in their own voice. For those that have good intact speech but just have trouble being heard, an amplification system like the chatterbox on this slide can be helpful for making a patient more intelligible. Care coordination should reach out beyond the clinic team to other areas of the institution. Working with anesthesiology is important whenever a patient needs surgery, so that pre-op clearance includes a plan for changing out the tracheostomy for one with a balloon, or using a hospital-sized ventilator if necessary. And also, how will that be reversed so a patient can go back to using home-style equipment? The trach team should work with the primary care team to assure things like good use of pneumococcal and flu vaccines. And there should always be a great open dialogue between the ear, nose, and throat and pulmonologist, keeping that line of communication open. We should, at every visit in the office, review why the tracheostomy is there and assure that ongoing needs for it have been met. We can review options for advancing the trach and helping families to plan for this. Finger capping to look at voice quality, monitoring capping only when you can be approved with safe ventilation being checked. And a family plan should be developed so that families understand when they can do monitored capping as well. Frequently, it can be helpful to ask families how often patients are being suctioned so that we can give them an idea of how necessary the trach is. And measuring peak cough flow, which is being performed on this slide above, will help us to know if the trach needs to stay in place. For instance, if the peak cough flow is less than 160, that tracheostomy will often need to stay in place. Whereas those who have a peak cough flow that's 270 will only be able to have the trach come out with aggressive airway clearance and cough assistance. Last, we'd like to talk about the fact that when advancement plans are in the final stages, that monitoring overnight is important to assure that sleep disordered breathing can be effectively treated prior to removing the tracheostomy, encouraging non-invasive ventilation as an alternative. Oximetry overnight, transcutaneous CO2, or even full polysomnography should be considered. Oftentimes at the removal of tracheostomy, we will work with our hospital staff, and the office staff is always important in this process. So I'd like to thank everyone, and I'd now like to pass off the screen to our team in Melbourne at Austin Health with Tina and Christine. Candace, I'm sorry, and Christine.
And also, I forgot to mention that, oh, they're there. Okay, I forgot to mention that we will be taking questions at the end. So be sure to write us some questions and we'll get to those at the end.
Thanks so much, Dr. Morris and Dr. Wolf. Really great insights, and although we do many things in a similar fashion, there are always new items that came up there and lots of food for thought. Greetings from Melbourne. I'm Tanis Cameron. I'm the manager of the Tracheostomy Review and Management Service at Austin Health, known as TRAMS, and it's a great pleasure to be with you today. Tracheostomy care around the world, tracheostomy safety around the world is improving, and there are great exciting things going on. We have international collaboratives, we have webinars such as this, very exciting work in the area of patient and family newsletters and forums. We have international tracheostomy symposiums and, of course, increasing numbers of publications. So that's tremendous news, but we have a long way to go. In Austin Health is a 900-bed tertiary care facility in Melbourne, and we operate across 3 campuses and manage tracheostomy patients across 3 campuses and into the community. In terms of case mix, Austin Health is a statewide service for the Victorian Spinal Cord Injury Service and the Victorian Respiratory Support Service, and that surely gives us a large number of patients that we see annually. We GTC, or the Global Tracheostomy Collaborative, and TRAMS adheres to key drivers, including multidisciplinary care, which you've heard so much about, coordinated policy, procedure, and education across all disciplines, increasing patient and family partnerships, and increasingly robust data collection. It's a great pleasure to introduce Christine Meacham. She's one of our clinical nurse consultants at TRAMS and at ICU Nurse. We also are very pleased to have had input from Jenny Macer. She's the mom of one of our patients. Jenny and Sally are unable to join us today, but they have kindly provided really solid insights that Christine will share. And as Linda said, there will be questions at the end of this session, so please type those in. Welcome, Christine.
Thank you. Thanks, Tannis. This is our disclaimer slide that I'll let you have a look at. So a hospital is not a home. Once it's determined that the patient cannot be decannulated, the focus becomes on tracheostomy care in the community. We need to ensure the smooth transition of patients from the acute care setting to the community setting, which requires a streamlined, safe, and coordinated program. Our tracheostomy safety and quality program is constantly being revised and improved. We get feedback from staff, patients, and family, as well as benchmark our program with our GTC member hospitals to ensure that our program is as safe, secure, and streamlined as possible. The two services at the Austin that work with the tracheostomy and ventilated patients are the TRAMS and the Victorian Respiratory Support Service, or VRSS, as Tannis has mentioned. Together combined, we see over 50 patients in the community in the state of Victoria in Australia. We are both very multidisciplinary, and we have a strong focus on patient-centered care and patient and family partnership to ensure the smooth transition of patients from the acute setting to the community. And we both have the following program goals in mind. We want to empower patients and caregivers. We want to support the patients and caregivers. And we want to prevent bed blockages and readmissions into the acute hospital setting. And we want to improve safety and quality of life. Austin did a 2-year retrospective study in 2011 and 2012 of our combined VRSS and TRAMS community trachea patients, and our study had 58 patients. We found that 82.8% were living at home, 17.2% were living in residential care facility, half and half were not, and the median time to survival was 52 months. We found that with the support of TRAMS and VRSS, patients with a tracheostomy had no unexpected deaths related to the trachea, and that age, underlying diagnosis, and the indication for the tracheostomy were related to long-term survival. So in summary, patients can live safely in the community with no increased detriment. Our TRAMS community tracheostomy program is composed of 4 parts. So we're going to talk about support, training, resources, and patient and family partnership in further detail. The first component is support. It's composed of case management, equipment management, tube changes, and community links. In terms of case management, we have office hour support available through telephone calls, emails, clinic visits, and hospital visits to deal with any troubleshooting. We also refer patients to specialist clinics such as ENT, thoracics, or respiratory if there's any new issues that come up that's out of our scope of practice. Our equipment management entails the yearly servicing and maintenance of the equipment as necessary, and TRAMS provides the ongoing supply and funding of all consumables and all equipment for our tracheostomized patients. This alleviates any financial strain they may be experiencing from family members losing income, etc. And it also provides conformity, uniformity, and consistency of equipment to increase the safety perspective. With regards to tube changes, ideally we prefer patients to come to our clinic for the trachea tube changes, as we're in the medical facilities and have access to medical staff, and also various members of our team can see the patient at the same time. Of course, there are patient populations who cannot come to the hospital, and we would have to go to the community to do the tube changes, such as those with high complex care needs that may need ambulances or carers to bring them to the hospital. With regards to community links, we ensure that on discharge that the patient is linked in with their local GP to be able to consult with, as well as to their local hospital if they live far away from our hospital. If patients For patients who are being discharged home, we make sure that the community nurse at the Austin visits the patient for a period of time to ensure a smooth transition to monitor and support the patient. TRAMS gives these community nurses checklists so that they can tick that off and fax it back to TRAMS so that we can keep on track of how the patient is doing in the community. If patients are discharged to residential care facilities, such as nursing homes or supported accommodations, then we work closely with the facility managers. The second component of our safety and quality program is training. A unique aspect of our team is that the same team that follows the patient in the acute care setting follows the patient into the community. The members of the TRAMS team that train are medical doctors, nurses, speech pathologists, and physiotherapists. And we work closely with the family members to support their safety and quality needs. We ensure that we train, that we have a highly structured training and that we train across the continuum. We use multiple approaches in that we use online videos, we use resources, we use simulation and lots of practical, and we ultimately train until they feel safe and comfortable with their care. We want them to be able to think critically and to respond to different situations, such as in an emergency. If patients are being discharged home, then it is vital that we have established a minimum of 2 core carers that will be available from the onset to be available for the training. As for safety reasons, we don't advocate for patients to be discharged home alone. For the patients who have to be discharged to a residence, they cannot be discharged home, then we ensure we provide structured and formalized training and education for the employed carers. And we work very closely with the facilities educators, and we also provide regular refresher training because in cases there might be high staff turnover or a high number of carers that are available. We train into a different number of topics such as anatomy and physiology, the reason for their tracheostomy, humidification, suctioning, stoma care, and speaking valve use. In terms of cuff management, we try to discharge our patients with a cuffless tracheostomy tube because we want to make their trachea care as safe and streamlined as possible. Of course, there will be patient populations that need a cuff trachea, but we make sure that they're fully confident in cuff management before discharging these patients. With regards to emergency management, we go over various scenarios for the patient and draft individualized emergency care plans for them. And we include situations such as the accidental dislodgement of a tracheostomy tube, as well as blocked trachees or respiratory distress. The next component of our quality and safety program is resources. We have an external website, tracheostomyteam.org, that is available for the public. So the patients, family members, care facility workers can log on, and we have 8 e-learning packages that they can go through at their own leisure, which covers all the training that we would have covered with them face-to-face. We also have videos on suctioning and emergency management. We also have our community tracheostomy training program online that is available for the care facilities and other hospitals to have a look at. We also have our About Your Tracheostomy patient brochure available. Another resource we have is the Tracheostomy Blue Book. This is the go-to book for all our patients, and we encourage them to take this book with them wherever they leave the home, including to go to hospital together with their tracheostomy emergency bag. We include emergency management first because safety is first, then the reason for their tracheostomy, equipment instructions, instructions on their consumables, and the specifics of their tracheostomy routine care. As I mentioned, we have brought about a tracheostomy emergency bag. As part of our training, we've been encouraging patients for years to take their charged portable suction unit with them, together with their spare trachees and their trachea blue book with them wherever they left home, including to go to hospital. But in reality, we found that patients were not doing so. And this had huge safety issues if they had to come to hospital and have the wrong trachea put in, or the emergency staff may not feel prepared for the complex tracheostomy care needs of the particular patient. We really liked the tracheostomy emergency bag that Dr. Karen Waters presented at a GTC meeting. And our Royal Children's Hospital in Melbourne were doing something similar, but we were not. So therefore this year, we've brought about the tracheostomy emergency bag, which contains a bright red sticker saying what it is, as well as a laminated card stating what to do in emergency on one side. And on the other side, it states the specifics of why the patient has a trachea, as well as the particulars of their specific tracheostomy tube, as well as a laminated sheet of paper that states what needs to be in the bag, namely the fully charged portable suction unit, spare size 12 suction catheters, the spare same size trachea, spare trachea smaller size, spare trachea ties, inner cannulas, and Swedish noses or HMEs. We wanted to do this because we wanted to make it as smooth and simple as possible for patients and give them the optimal opportunity to succeed. We've found that our patients, families, and the care facilities have really embraced this practice, and we're excited about this. Another resource we have is safety alerts and links, where our hospital trachea patients have an alert put on Cerner, our online hospital database and information technology for health services, so that when they come to hospital, it alerts the ED emergency department workers that this patient is known to the various departments in the hospital and that they need to alert trams about the patient's admission, so that this makes a speedy admission and for the patient to the hospital and to be seen by the relevant team, so they don't have to wait in the emergency department for prolonged periods of time. We know that our other GTC member hospitals have emergency services alerts that are in place, and we really like that idea, but have struggled to implement this to date. We've saved the best for last, our patient and family partnership. This is the strongest component of our quality and safety program. Our patients and families have been a vital part of our quality and safety program in that they give us input into our training program. They have presented at workshops. They have helped us with our resources, such as our e-learning packages and our booklets, and they've helped to network and resource with each other. At TRAMS, in collaboration with the Austin and the GTC, we've been hosting patient and family forums twice yearly, where there are over 40 past and present tracheostomy patients in the group, together with families, clinicians, healthcare facilities, and healthcare providers, where there's a lot of discussion and ideas generated about quality, safety, and other topics as patients share their stories and they share their experiences, and we really learn with each other. Consumer engagement is a vital part of a quality and safety program because it is a reality check to us, and it makes sure that we're all on the same page and we are listening to their voice and their concerns, as they are the most important piece in our work. As Tanis has mentioned, Jenny Messer, who has her daughter Sally, who is a patient on one of our wards, could not be with us today, but she had some points that she would love to share with us that I'll share with you now. She states that we need to have clear and extensive communication. We need to remember that to be problem solvers and not problem creators. We need to be able to include the patient and the family in any of our discussions and our decisions and to involve them. We need to show respect because the patient with a tracheostomy may have lost their voice and this is their new normal, but we need to respect that the family members are their advocates and their voice needs to be heard as they're advocating for their loved ones. And lastly, we need to show compassion and empathy and to be able to support them in the best way that we can. So in summary, a hospital is not a home. We need to ensure that our care and our quality program is patient-centered and patient-specific. We need to ensure our program is structured and streamlined, and we need to maintain strong links and communication between hospitals and the community. We need to continually benchmark and improve our processes, and that's why it's so important to be a member of the GTC. And most importantly, we need to partner with our patients and families as they're the most important part of our work. Here's a slide on our presenter email addresses, and now we'll be opening up the webinar to questions.
Hi. I'm told that in order to write a question, you need to use the question mark icon, and then you're able to type in a question. Okay. We did have a couple of questions come in early, so why don't we start with those to give people a minute or so to type in some questions. First of all, the question is, what are some difficulties in creating your multidisciplinary team? I can speak from my experience. I know that when I was in an acute care hospital, I found that there was difficulty in that, we had people from different disciplines with great expertise, but it was the question of getting people together. It was time frames. It was difficult to manage, and everybody had very busy schedules, and it was difficult to get people together. However, since I've been in a rehab environment, the rehab environment here is very multidisciplinary by nature. So it just kind of happened very easily here. Getting people with an interest in tracheostomies was really pretty easy. We have representatives from every unit, including nursing, all of the therapies, respiratory, speech, PT, OT. Even we have patient care techs who want to be a part of it as well, because it's important work and everybody understands that. So that was that question. Anybody have any comments about that?
Linda, it's Janice here. You and I have talked quite often about what the barriers are to MDTs. And the recurring theme, as you suggest, is resources, time commitment, and resource to coordinate such an effort. Yeah. And I think the culture in certain facilities is more conducive to that than in others. But I think that the literature worldwide is now showing through meta-analysis that the multidisciplinary team approach is the strongest to patient care. So thankfully, I think even in those centers who are reluctant or who are having more difficulty coordinating care have an increased base with which to advocate for such an approach. Thank you.
That's great. I've got a question in here and I'm having trouble reading it. Let me open this up a little bit here and see. Oh, I just moved it to the other side. That didn't really help, did it? One question here, a little off topic, but would like to use the expertise of the listeners. I really struggle with finding an occlusive dressing post immediate decannulation. Does anyone have any suggestions? It's by Tracy Nichols. Any suggestions about an occlusive dressing that they use immediately after decannulation?
Yes, so I can comment on that, Linda. So immediately post decannulation, we clean the stoma with normal saline, and then we use Cavalon swabs, which is to prepare the skin to help the dressing to stick. And then we place steri strips across the stoma. Then we take our dressing pack, and there's a gauze in there that we fold in 4, and we place it directly over the steri strips. And then we place a clear film or opsite over that. And then we can place an ECG dot, which has a metal part on it that the patient can press for voicing or for coughing. And we ask the nurses to leave that dressing intact for 3 days, because that will give the stoma adequate time to close. But if it does lift, they can reinforce it, or if it's heavily sore, then they can replace the dressing. And that seems to have helped a lot with our decannulated patients.
This is Lisa Wolf. The other thing is, if the patient is going to be using non-invasive ventilation, as well. We recommend placing a Vaseline gauze before doing the final dressing so that you can get better adhesion and you'll get less air leak and really allow for non-invasive ventilation while the stoma is healing.
Interesting.
Personally, my experience is kind of different. I haven't really used an occlusive dressing. I've just used gauze and then taught the patient to, when they want to speak, just to cover it here. I think it came from, I've read at least one paper that reported a tracheoseal as a result of some coughing after immediate decannulation, and then it resulted in that. But I haven't used an occlusive dressing. I know other people do. Let's see, another question is, I have to read this one line at a time. I'm sorry about this. A question about trach rounds. What disciplines are routinely involved? Well, for me, everyone is invited. We don't always have participation from all the disciplines. Typically, nursing is there, but respiratory they're probably one of the most important people to be there, but they haven't been able to come consistently, let's put it that way.
And one of the other things that I've noted when we make rounds with the trach care team rounds is that the student nurses, the younger nurses, are really encouraged to come with us as part of the learning process. And that's been very helpful because even though they go through orientation before going on the ward, it's different because when they actually have a tracheostomy patient, they have a whole slew of questions that don't come up until they're in that situation. So the student nurses have been very important. And then lastly, one of the things that we find is that often we can make assessments that the team has missed, like we think someone's ready for advancement or decannulation. We can meet with the doctors or even leave them notes afterwards to tell them what our findings are. One of the good things, yeah. One of the only other things I was going to say about making tracheostomy rounds is a little bit, we're like the police. They know that we're going to be checking where all the supplies are. And because we come at, sort of intermittent times, we get the best enforced behavior because they never know when we're going to show up in a room. So that can be helpful.
I have another question. Another question from Bridget from Southwest Florida. Do you use inline suction catheters or open suction for children on ventilators?
Does anyone have an opinion on this? Because otherwise I have an opinion.
I have an opinion too, but
we've never talked about this, so it should be interesting. I will tell you that my concern about inline suction, especially for patients who are going home, is that it's a lot of weight. And that weight causes two problems. One is that it can cause the stoma to dilate, which is problematic. And the other is that that weight going forward can cause accidental decannulation. That accidental decannulation is the single highest risk in terms of safety issue for home-based patients. And because of that, we prefer not to do inline suction for home-based patients.
That's exactly my concern too. And it's for in-hospital patients as well, because I can't tell you how many times I'd make rounds in the ICU and I would see at least every day traction from the ventilator tubing and the whole ventilator circuit with all of the additions, the inline suction, the, HME and all of that stuff, the filters pulling down on that trach. Yeah. How about you guys in Australia? What's your experience?
We don't use inline catheters, and I've used them overseas, and I agree with your comments.
Yeah.
Yes, I've only seen it used in the ICU, but it does carry a lot of weight, and once they're in the ward, no, we don't use it.
I mean, they're very
Yeah.
convenient for nursing. I won't deny that. They're very convenient.
Well, and
but
for ICU patients who have high levels of PEEP, inline suction allows you to keep that PEEP intact. And for an acutely ill patient, that's absolutely necessary. But by the time we're looking at patients who are stable and ready to transition to the home, you know, PEEP is not, it's not necessary to keep that intact circuit for PEEP. Even if we have PEEP, we may be using it, say, to improve speech. It's not necessary in terms of oxygenation.
yeah. Okay, another question. How is your 3 hours of therapy distributed amongst the different professions in the hospital? That's a good question, and it's very regimented. The case managers are responsible for putting together the schedule for every patient, and I don't know how they do it, but it's.
So the physiatrists are the ones who really evaluate patients and decide how it should be distributed based on patient need, but also based on best estimates for progression. So the goal for doing rehab is to see growth. So if there's the greatest growth potential, that therapy gets the most time.
Yeah. Okay, here's one. Thank you, I agree. I'm not sure. I'm sorry, I'm reading this one line at a time. I'm constantly battling the RT staff on this. I'm not sure
Yeah,
what.
probably the suction issues.
Yeah.
So, yeah. I will tell you that one of the big differences between a tracheostomy patient and an intubated patient is that in the intubated patient, keeping that circuit in place and not opening it helps to reduce ventilator-associated pneumonia. And I understand where the respiratory therapist is coming from. But once we have a tracheostomized patient, we're now looking at a different phase of the disease. And in that phase, the presence of tracheobronchitis is the thing that's really driving the ventilator-associated pneumonia. So if we see an increasing need to suction, the idea isn't to put an inline in to more easily suction. The idea is to actually sample those secretions and say, is there a better way for us to handle this, treating the tracheobronchitis, not just adding extra weight to the circuit. And I think that what we need to do in terms of education and research is to promote a better understanding of the difference between risk of ventilator-associated pneumonia in those that are intubated versus the chronic tracheostomy patient.
Yeah, that's great.
And for the Melbourne folks, I'd like to throw back some of that suctioning issues to you. Do your patients have a hard time getting a sufficient number of suction catheters? That's a big issue for our patients in the States.
The TRAVS program does provide equipment and consumables because we are a funded program at Austin Health, and we've built that into our standalone budget. So I think that the funding issues are so very different in the US compared to Australia. But we feel fortunate that we do have that situation for Austin Health patients and those with tracheostomy, the same with a ventilator.
Great. I have another one of the early questions. We have a few minutes left. What are the barriers to the safe discharge of patients home? Christine and Tanis, can you comment?
Yes, so as I guess what I was saying earlier, that ideally if a patient will be discharged home, they should have 2 core carers to be able to be available for training and to be able to be at home with the patient. But not in every circumstance that there is someone who can be with the patient when they go home. And also another aspect is the residential care facilities. Not a great number of them are prepared to take tracheostomy patients, and they require a lot of training and support. And there's few and far between in Victoria that do take tracheostomy patients. So those are two of our biggest barriers that we're experiencing with discharging patients out of the hospital. Good.
Is that similar in the United States, Linda?
Yeah, I mean, we are limited in terms of having long-term care facilities that are comfortable with taking care of patients with tracheostomy. And often patients will end up not in their immediate local area so that they can get tracheostomy care. In terms of training family members, we have the same standard of 2 trained family members if the patient especially is going home not just with tracheostomy but with mechanical ventilator. If the patient is going home with tracheostomy as a single indication, we frequently will have patients go home independently if they can demonstrate that they are very skilled and can take care of the trach themselves.
Yes, occasionally we will as well.
Okay.
Are you using teleconferencing for many of your patients over there?
I didn't hear you. What did you say?
Are you using teleconferencing for your patients who are at long distance at all?
No.
So it is very limited in the States. We are at our infancy and doing real-time video conferencing. So for instance, our Veterans Administration is doing this routinely, and some of the fully integrated systems like Kaiser Health can do that routinely. So for instance, at our institution, 2 parts of our clinic can do it, the rest of us can't, and the rollout is going to be very slow. So I would say still in the infancy.
Thank you.
Right. Well, we're at the end of our time here, and I want to thank everybody for joining us. We've had a great and lively discussion, and I want to invite all of you to attend our next upcoming GTC webinar on December 4th in the States, on the 5th in Australia, on pediatric tracheostomy decannulation. Thanks everyone for joining us, and good night.
Thank you.
Thank you.
Good morning to you guys in Australia.